Hello everyone and welcome to today's Connect and Learn webinar. It's great to have you with us today. My name's Sandra Rogan. I'll be hosting today's webinar, which is Pharmaceutical Opioids, What AOD Workers Need to Know. But before I continue, I'd like to acknowledge the traditional custodians of the land on which we're gathered, the Wurundjeri people of the Kulin Nations, and pay our respects to elders past, present and emerging, and extend this respect to people from all Aboriginal and Torres Strait Islander communities. If you're new to the webinar series, the Connect and Learn has been designed to support AOD clinicians throughout the regions and metropolitan Victoria, and we also welcome our interstate viewers too. This webinar series is hosted by Turning Point and funded by the Department of Health and Human Services in Victoria. You've got some useful tools up on your screen, and to make the webinars as interactive as possible, please use the functions in the top right of your screen to ask questions at any time throughout the webinar. And part of my role will be to collate comments and feedback and questions that come through from you, and there'll be time at the end of this webinar for our facilitator Susie to respond to the questions. If you can, we encourage you to stay to the end of the webinar and complete the exit survey. On this survey, there's an opportunity for you to provide feedback and suggest topics for future webinars. If you do have to leave early, you can click on the yellow feedback icon and the survey will open in your computer's browser. Now I'd like to introduce Associate Professor Susie Nielsen. Welcome. Susie is the Deputy Director of the Monash Addiction Research Centre in Melbourne and is the current NHMRC Career Development Fellow. Susie also holds an honorary professional appointment at Turning Point Alcohol and Drug Centre and is honorary Principal Fellow at the Burnet Institute, is a co-joint Senior Research Fellow, National Drug and Alcohol Research Centre in New South Wales, at University of New South Wales, Sydney, and is an honorary research fellow at the Alfred Hospital Pharmacy Department. Susie is well known to us in the sector, and she's a registered pharmacist for over 20 years with clinical experience in the treatment of substance use disorders and includes in specialist drug treatment and community-based alcohol and drug treatment settings in Australia and in the United Kingdom. She's published over 110 scientific publications and given over 170 national and international conference presentations on her research, which has led to a greater understanding of how to identify and respond to prescription and over-the-counter drug-related problems. Her recent work has a focus on reducing opioid-related harm and overdose prevention. So I'd like you to all welcome, and I'm very grateful if you're making yourself available in your very busy schedule. Welcome to our Connect and Learn webinar.
Great. Thank you, Sandra, and thanks for the invitation to be here and talk about an area that I feel very passionate about. So as many of you may be aware, pharmaceutical opioid dependence has become incredibly topical, and particularly with the introduction of SafeScript in Victoria, we may start to be identifying patients who use high amounts of opioids, and some, though definitely not all of these, may need referral to AOD treatment, or they might be asking about what options they have. So today I'm going to cover some of the pharmacotherapy treatment options for opioid dependence, which also is often termed opioid use disorders or addiction, and I will cover a little bit of terminology. I'll talk a little bit about some of the barriers to treatment, particularly those that might be unique to people who use pharmaceutical opioids. And then I'll provide a little bit of information that hopefully will be relevant to talking to people who are considering these treatments, and a little bit how you might tailor this information to be relevant for those using pharmaceutical opioids. So before I start today, I wanted to introduce a case, just to kind of put a human face to this information. So I'm going to introduce Helen. Helen is a 49-year-old woman, and she's got a 15-year history of codeine use. So previously she was using over-the-counter codeine, now more recently prescribed codeine, and also some oxycodone use. So Helen started using these medicines for headaches, and she increased to daily use within a few years. That use escalated when she separated from her partner, and she was taking sort of 45 to 60 tablets of over-the-counter codeine for a period of time, and then she moved to prescribed codeine, and then in the last couple of months, oxycodone 5 milligram tablets as required. Now she's taking 4 a day of those, in addition to a pack of Panadine Fort every day or two, occasionally from a second prescriber. So the GPs recently queried her increased frequency of use, and the GPs suggested that they might not be able to keep prescribing these with the implementation of prescription monitoring. So Helen now is really feeling a little bit concerned about what might happen for her. So after we go through the information today, I'll come back and talk about Helen. So to start with, I wanted to talk a little bit about how common it is that people experience what's often termed as addiction or opioid use disorder, problems with prescribed opioids in general. And I think the answer is it's more common than you might think. I know when I trained as a pharmacist, we were told if people had pain that they couldn't really develop addiction or dependence. We know now that that's not true. And internationally, there have been reviews looking at how common it is that people with chronic non-cancer pain, for example, develop addiction. Internationally, that's been estimated at between sort of 8 and 12%, but many of those studies actually haven't specifically questioned about what people are experiencing. It's only where it's been reported anecdotally. In Australia, we've had a couple of studies that have really looked at this question in detail, and one of those is the Pain and Opioids in Treatment study, and this found that 1 in 4 patients using long-term opioids for chronic pain actually met criteria for addiction. So this is when we're talking about impaired control over use, compulsive use, continuing to use opioids despite experiencing harm and experiencing craving. So these kinds of symptoms. A separate study that I led has looked at, it's the ROOM study that looked at routine opioid outcome monitoring in community pharmacies. And again, a completely unrelated sample, but very similar findings where 1 in 3 patients in that study met criteria for having any kind of opioid use disorder, and 1 in 4 patients met criteria for moderate to severe opioid use disorder or dependence. So you can see 1 in 4 patients, it's actually quite common that people might be experiencing some challenges. Now, not all of these patients would necessarily need to be referred to treatment, but I think it's helpful to be able to let patients know that they're not alone, and this is actually a relatively common side effect with prescription opioid medicines. I know that many people are probably aware of these definitions, but just so it is clear what I'm talking about, I wanted to cover a little bit of terminology. So when we're talking about opioid dependence, this is a technical term covered by the ICD-10, and this is not just physiological adaptation to opioids, which we know is common and expected when people use these medicines long term. It's also additional behavioural aspects. So there are some physical aspects, developing tolerance, experiencing withdrawal, but there are also these patterns of use, including taking more opioids than intended, being unable to cut down, spending a lot of time obtaining opioids, and maybe foregoing important activities in someone's life because they're really focused on that opioid use, and continuing to use opioids despite knowing the harmful effects or experiencing harm. So having 3 or more of these symptoms in 12 months would meet the criteria for opioid dependence. A more simple definition that often clinicians use is called the 4 Cs, and that is looking at these 4 symptoms of experiencing craving, a loss of control over the amount of opioids used, compulsion to use, and continuing to use despite consequences. So when you're talking to patients about how they're experiencing their opioid use with prescription opioids, asking about some of these symptoms might help to understand if someone is having problems and if referral to have a more formal assessment might be appropriate. One of the reasons that we're talking about this and why SafeScript has been implemented is because we have seen these really dramatic increase in harms with pharmaceutical opioids. So you can see on the graph there, the orange line is all pharmaceutical opioid-related deaths, drug-induced deaths in Australia, and the blue line is heroin. So we can see that they're both increasing, but the sheer number of deaths with pharmaceutical opioids is more than double that we've been seeing with heroin. Most of these deaths are classed as accidental, although I would note that most suicides in this database do involve prescribed opioids, and they are a little bit less likely to be accidental. And so we do also need to be thinking about mental health in this population. So moving on to the topic today, talking about pharmacotherapy for pharmaceutical opioid dependence. So I wanted to talk a little bit about what some of the options are, and I am really focusing on those medication-based options. There are obviously a range of psychological therapies which would also be appropriate, but that's not the focus of today. So I wanted to talk about opioid agonist treatment. Now, you've probably heard a lot of abbreviations. Sometimes this is called OST, opioid substitution treatment, or or ORT, opioid replacement therapy. These are all referring to the same thing, but I think opioid agonist treatment is currently the preferred term just because it's less stigmatising, but you will hear all of those terms used. Now, I guess one of the things to note is that it's probably not going to be appropriate for all patients who experience problems with pharmaceutical opioids. So it is important to think about which patients it might be good to start having conversations about these treatments with. In terms of where it's appropriate, it's going to be most appropriate where we have confirmed that the person actually meets diagnostic criteria for opioid dependence that I mentioned just in the previous slides. And also perhaps where there's already been some attempts to use, I guess, sort of earlier strategies. So maybe the patient's already tried to reduce off use themselves without opioid agonist treatment, or they've tried to kind of manage with stage supply, picking up regularly in a community pharmacy. Those kinds of things haven't worked. That might be when we're looking to step up to looking at an opioid agonist treatment like methadone or buprenorphine, naloxone. Also, we might want to move to this as an option where there is either risk or already the patient's experienced an overdose, or they've tried to taper off and they've relapsed to use, which can, again, put them at risk. And importantly, we'll discuss this a little bit today, we need to have a patient that's willing to consider opioid agonist treatment. And I think that's where the AOD clinician's role is so important, is being able to bring up the option and have patients feel familiar and comfortable with this as an option. Many patients, when they're kind of earlier in their problems with pharmaceutical opioids, if you start talking about treatments for opioid dependence and referring people to drug and alcohol services, that's going to be very confronting. So being able to bring our patients along with these conversations so that they're willing to be able to consider it is really important, and I will talk about that more. So the two main opioid agonist treatments that I'm going to talk about today are methadone and buprenorphine. Methadone is available as an oral liquid and it's a full opioid agonist. Buprenorphine is a partial opioid agonist, and I'll talk about what that means on the next slide. But buprenorphine is available in a wide range of forms. So we've had sublingual tablets, sublingual films, which are on the left and right of the screen. Also, very recently, it's become available in a weekly or a monthly injection. And we have actually coming up on this same series a full webinar that's dedicated to looking at these depot buprenorphine options. So if you're curious to learn a lot more about those, I won't cover them in too much detail today, but do register for the next webinar that's going to focus on those specifically. So just a little bit of pharmacology, and apologies to anyone that this is either very unfamiliar or very familiar, but I just wanted to highlight some of the differences when I say an opioid is a full or a partial agonist. So morphine, heroin, methadone are all considered full opioid agonists. So what that means is when you increase the dose, you increase the response, and that can be great when you're trying to get increased, for example, pain management, but you can hit a point where you can get respiratory depression as the side effect. And as the dose keeps going up, the risk of that increases, and it can actually be fatal. So that's why with some of these full opioid agonists, we are a little bit careful. Methadone in particular can have this side effect of reducing respiration, and we have to be a little bit careful with it. Buprenorphine is called a partial opioid agonist, so it still has opioid effects, but when you keep increasing the dose, you get to a point where you experience what's called a ceiling effect. When that is with respiration, that actually confers a relative amount of safety. You can't actually, when buprenorphine is used on its own, you generally won't increase the dose and get to a point where people's respiration is compromised. Of course, when people are using multiple substances together, that's not necessarily the case, so we still need to be careful, but it does have a little bit of a better safety profile. And then there are things like opioid antagonists, so things like naltrexone and naloxone. These don't have any kind of opioid effects, they just block the effects of opioids. So now I wanted to talk about a little bit of some of the variations in how treatment is delivered, and this is often something that we need to be able to talk about with our patients. So often options that people are considering is a taper, also often referred to as detox or opioid detoxification or withdrawal, versus long-term maintenance. So there are advantages of short-term treatment like detoxification. So often it's a really good entry point for people that don't want to try a maintenance or a long-term treatment. It requires a shorter term commitment. So often, particularly with pharmaceutical opioids, it's quite common that people are employed. We see that much more commonly, and then entering treatment can be a little bit challenging to be able to attend a pharmacy daily. So maybe a short term program is something that they might be willing to try. But there are disadvantages to also consider when you're talking through options with patients. So we know with pharmaceutical opioid dependence that typically very few people will have a successful outcome from a short-term detoxification. So a week to 7 days being supported to reduce off their opioids. So some studies have looked at either 2 weeks or a 12-week kind of short-term period of treatment and found that 9 out of 10 patients will actually relapse back to opioid use fairly quickly after finishing that short-term treatment. So I think if you're considering this or talking to patients about maybe having a short-term treatment, let them know, look, it's unusual that will be enough. We can give it a try. But if you do find that you return to opioid use, come back and we can look at other options for you, and to let people know that they're not, that they haven't failed, that it's very normal for these treatments not to work well in the short term, and often people will need a little bit longer. The other thing that is important to talk about with patients if they're considering just doing a short-term treatment is that it can actually increase their risk of overdose. So when you reduce off your opioids, you lose your tolerance to opioids, and then that can place you at increased risk if you return to opioid use later and you haven't been used to taking that same dose of medicine. So it is also important to make sure patients are aware of that. And very tragically, we do see that the risk of mortality can increase after people have had these short-term treatments. In terms of the evidence for taper versus maintenance, for people that like to be able to refer to this when they're having conversations, there have been a number of studies, 3 in particular studies, relatively small sample size in total, so we would consider this low quality evidence, but they have shown that treatment outcomes for people with pharmaceutical opioid dependence are better with longer term treatment. So they're more likely to stay off using opioids and they're more likely to stay in treatment as well. So far we would recommend in general, based on the evidence, that maintenance treatments are going to be the more effective option. But as I've mentioned, often the shorter term treatments might be a pathway, kind of getting familiar with these medicines, and it may be an exposure to the first time for a medicine like buprenorphine, naloxone, that can then lead to engagement with longer term treatment. So, I mean, we never talk in absolutes. Often we just need to work out what's best for the patient. Now, the other question is often whether or not methadone or buprenorphine might be a better option for a patient. So again, this is from a Cochrane review that was completed a couple of years ago that I was involved in. We looked at the evidence for whether or not patients who were dependent on pharmaceutical opioids would do better on methadone or buprenorphine, and what we found was there was no difference in how well people were retained in treatment, and there was no difference in how well they were able to reduce or abstain from opioids while they were in treatment. So the outcomes were fairly comparable. So I guess what this means for treatment is that we can look at other factors, so what the patient might prefer, the safety profile. As I've mentioned, there might be some benefits of buprenorphine, naloxone over methadone, side effects that patients are worried about, and also the options for unsupervised dosing. So we know, for example, with buprenorphine, in Victoria, patients can get weekly or even monthly dosing when they're stable, and that can really make it easier to maintain other commitments like education or parenting or work. So that might also inform the decision. And again, mentioning that we've got the buprenorphine depot, and again, that's going to sort of free up options. So being able to look at all of those factors that might influence which medication might be best. And in general, when we've looked at what predicts how well a patient does in treatment, it can often be what they believe will work for them. So that's a very important factor. I wanted to talk a little bit about some of the differences between methadone and buprenorphine in terms of those practical aspects. So in terms of the induction process, I'm going to cover that on the next slide, so I won't talk about that in detail now, but there are some important differences. In terms of opioid blockade, again, there are some differences. With both methadone and buprenorphine, you can generally get up to a dose where the effect of opioids on top are not felt. So what this can help do is break that cycle of where people use additional opioids while in treatment. They're not as reinforcing, and so that helps people stop using them. So typically a dose of around 16 milligrams of buprenorphine is enough to achieve that, and around a dose of 100 milligrams of methadone. There is a difference in withdrawal onset and severity, so how long it takes for people to experience withdrawal symptoms and how severe those symptoms will be. So typically we often see with methadone that the withdrawal symptoms might be slightly more severe, and people do find it a little easier to taper off buprenorphine. And this is the reason why buprenorphine is often preferred for a short-term taper, and also, I guess, because of its safety profile. There's also a difference in access to unsupervised treatment. So you can more easily access unsupervised doses with buprenorphine naloxone, as I've mentioned, and particularly with these new depot formulations, there'll be more options for flexibility in treatment. And I think it is really important to let patients know before they enter these treatments the kinds of impact it might have on their life and the restrictions, so they're able to make an informed choice. The final issue that can vary between these two treatments is cost. Now, the cost is actually typically borne for the supervised dosing by the patient. So the cost of the medication is covered, but not the cost of the pharmacy providing the service. And it's not regulated, so it can vary greatly between pharmacies. And it also varies between whether or not somebody's having a supervised daily dose or maybe getting weekly or monthly dispensing, so there can be a cost saving. But that varies, so it's really important that patients know to ask how much it is at that pharmacy and maybe ask around if they've been told a particularly high cost. But daily dosing, it's usually in Victoria around $5 to $8 a day, sometimes with discounts for weekly payment or paying ahead. And again, it varies, so really just checking in with a pharmacy before deciding where to go. In terms of induction with these two different treatments, again, it's important to understand how they differ so we can prepare patients for what they might expect. And I'll mention this a couple of times, but in general with patients on pharmaceutical opioids, they have a lot less information or knowledge about these treatments. They generally aren't linked in with peer networks to know these things. So some of these things that we know might be well understood by people who inject drugs or people who've typically used heroin. These are generally pretty unfamiliar, and we need to walk through each of these things with patients. So methadone, the pharmacokinetics of methadone are a little bit complex. It takes a while to reach steady state. So we often say sort of 3 to 5 half-lives, which equates to 3 to 5 days. So you can't increase the dose every day. Typically, we need to have the same dose for a couple of days to see how a patient's feeling before going up. And it is important to prepare patients for that because they'll often be anxious. They say they're experiencing withdrawal, and they most likely are, but with another day or two, that dose will accumulate and patients will feel a little bit better. So to explain to patients how that works and that you won't increase the dose till you've seen how they are for a couple of days on that dose. Misjudging that level or accumulating too much methadone can lead to overdose, and that's why in the first couple of weeks in treatment in particular, we go up very slowly. So the saying with methadone is always start low, go slow. So the usual starting doses is typically 20 to 30 milligrams. It's never more than 40 milligrams. And particularly where people might have polydrug use, so for example, patients who are also on other sedating medicines, or it's not clear their level of dependence, you'll start at a lower dose. Buprenorphine, on the other hand, we see less respiratory depression, so we're less concerned around safety. We almost have the opposite concern, that we need to make sure people are in enough withdrawal because we can precipitate withdrawal, and I'm going to go into that on the next slide. So the main thing with buprenorphine that we need to prepare patients about is that we don't start the first dose until they have observable withdrawal symptoms. So, for example, sweating, dilated pupils, stomach cramps, muscle pain. And we'll often do a test dose and then increase the dose quickly if people are tolerating it. One of the things about this population of people using prescribed opioids is often they haven't actually experienced really significant withdrawal symptoms. So we know with people who use heroin, often they've had periods of time where they have been able to access heroin and they're very familiar with what those withdrawal symptoms are. Often with people who are taking prescribed opioids, they've been taking them regularly, they've always had a supply from their doctor, and they may not have experienced this. So we do really need to prepare patients for what those symptoms are and to, I guess, address the anxiety that they might have around experiencing those symptoms. So just very quickly, I don't want to go into too much detail, and I'm sorry if you're already familiar with this from working with other patient populations, but it is important to remember that if buprenorphine is given while people still have other opioids on board, we can cause this precipitated withdrawal phenomenon where the buprenorphine enters the body, it knocks the opioids that are currently on the receptor off the receptor, and because the effect of buprenorphine as a partial agonist is a lower effect, what people experience is a relative withdrawal, a less opioid effect, and that can be really uncomfortable. So that's the reason that I'm just trying to explain this so you can prepare patients for why we want them to be in withdrawal before they have their first dose. So in terms of buprenorphine induction, while this is a concern, and I have maybe laboured the point a little bit, the research that we've done to look at how likely this is to occur, it's not any more likely or any more of an issue with pharmaceutical opioids and heroin, and it doesn't seem from the research that's been conducted to be any more likely with different pharmaceutical opioids. So using the normal precautions and processes around buprenorphine induction work perfectly well for this client group. But I would note that in all of the studies, they've generally had pretty standard protocols, and they always start people when they're in with mild withdrawal, and that's the important point. And generally when patients have less withdrawal, there is a greater risk of precipitated withdrawal. So really getting to that sort of, really being able to observe at least mild to moderate withdrawal symptoms. And again, just to note, and I think I've already mentioned this, that patients on pharmaceutical opioids just aren't necessarily going to know what opioid withdrawal symptoms are and what to look out for. They haven't necessarily had peer networks and have heard of precipitated withdrawal. And in some of the studies that I've been involved in, it's been much more important for us to educate people who have been using pharmaceutical opioids. They just aren't familiar with these symptoms. Another question that often comes up is, do we need the same kinds of doses as we often see when treating heroin dependence? And does treatment differ depending on what opioid you're using? So, for example, a weak opioid like codeine versus a strong opioid like oxycodone. And what we've actually found is it doesn't actually matter that much which opioid. Standard induction procedures seem to work, and people typically need the same kinds of doses that we're used to seeing with other opioid dependents. So typically stabilising doses of 12 to 16 milligrams daily. We say that even where people are using these weak opioids like over-the-counter codeine. And we know that the dose of buprenorphine in patches is often insufficient. So people often ask whether or not we can use the patch rather than having people enter in this treatment. The dose delivered by a patch, it's only about 1 or 2 milligrams a day, even with the highest strength patches. So usually it's not enough for this patient group if they have actually developed a meaningful opioid dependence. The other question that I often get is, should we use opioid dose conversions? We're used to converting to oral morphine equivalents with prescribed opioids, and often you will get sort of calculators that you can use. These are not useful for predicting doses of methadone and buprenorphine, and so really the dose needs to be titrated to the clinical effect for the individual patient rather than trying to use calculators to predict the dose. And I've just got reference to a couple of studies there where we've looked at that in detail. And I've got a tiny little cartoon on the top right-hand slide, which is a bit of a Goldilocks with this kind of, just getting it just right idea. And the other question that we often get is, what about pain? How does that influence treatment outcomes? Because we know many people who are using pharmaceutical opioids have often started using them because they've got a chronic pain condition. Now, I'm going to let you know that this is probably where the evidence is a little bit thinner. So there have been studies that have compared outcomes depending on whether or not somebody had pain at baseline. And they've had mixed results. So sometimes they find people with moderate to severe pain actually do better during treatment, but after treatment they don't do quite as well. And also people with pain might maybe have slightly more self-reported use at follow-up. And maybe that makes sense when some of those supports sort of fall away, that people might return to other opioid use. But many of the studies have specifically excluded, the larger trials excluded patients who have really significant pain. There has been one small study that particularly looked at a randomised controlled trial comparing methadone and buprenorphine in patients who had chronic pain and opioid dependence, and both groups had meaningful reduction in pain. There wasn't a big difference in between them. There's also been a number of, lower evidence studies that have looked at sort of following up patients when they've gone on to buprenorphine. And so these have been studies that have looked at patients who are taking high doses of oxycodone, even sort of 200, 300 milligrams a day of oxycodone, and transferring them onto buprenorphine. And what these studies have demonstrated is patients typically need normal doses, so stabilising on 8 to 28 milligrams, very normal dose range of buprenorphine. And actually those patients on the higher doses tend to show even greater improvements in their pain and quality of life after they've been stabilised on a buprenorphine treatment. So again, it's early evidence, but I guess what this means in terms of conversations with patients is that if patients have chronic pain, it shouldn't be a barrier to them doing well in opioid agonist treatment, either methadone or buprenorphine, naloxone. And so I guess being able to refer to the fact that there is some research showing that if anything, their pain won't be any worse, and most likely it'll probably be a little bit better once they're stabilised on these treatments. So I wanted to talk about barriers, and this is something that does come up a lot, and I think it's really important to prepare our patients for thinking about things that might affect them. So there are a couple of key barriers that people can encounter. The first is cost, and I think we do need to acknowledge that if we've had a patient that's been getting pharmaceutical opioids, a large quantity once a month with 1 or 2 PBS scripts, that's probably been costing them, $6 or $12 a month roughly. If they're going to transfer onto pharmacotherapy treatment, that's $5 a day. It is a disincentive, and we do need to think about that. The other point to cover is the stigma. So there is enormous stigma around substance use treatment, and many people who use pharmaceutical opioids might actually stigmatise other groups of people who are in treatment, and I think being able to think about that and think about how we talk about that is important. Access to treatment is important to think about. Again, if someone's been getting a prescription once a month, the daily requirements of going into pharmacotherapy treatment at a pharmacy, might be perceived as a barrier, and you might need to think through the pros and cons of entering these treatment, and I guess bring patients along to the benefits of what treatment might offer, which is balanced with the kind of restrictive nature of treatment, particularly in Australia. We also know that not all GPs will prescribe these treatments, and we desperately need more GPs to be prescribing these treatments. We do know that this is changing slowly, and in many states of Australia, and particularly in Victoria, GPs can prescribe for a small number of patients without having to do a long amount of training. They can start up to 5 patients without doing any training at all. So this does mean that we can get patients to be treated with their own GP rather than necessarily having to find another GP. And there are a range of supports for patients to do that on the Department of Health website. Sorry, for GPs to access information about that. But all of these things, I think we just need to acknowledge it's more complicated than getting a prescription a few times a month. And so talking through these issues and preparing patients for what treatment might be like is important. So I just wanted to have an idea about how we might introduce treatment, and I guess thinking about Helen and where she might be at. There's lots of things that are involved in treatment. People need to be registered for a permit. They need to attend the pharmacy regularly. They might need to think about being identified as someone who has an opioid use disorder, being registered for the treatment program. And some of these things take a while to kind of, I guess, come to terms with. And as I've already mentioned, unlike people who inject drugs or are PWID, as it's often abbreviated to, many of the times when we have patients thinking about treatment for the first time, they don't know anybody else that's been in this treatment. They haven't had any information. And so we do really need to bring people up to speed with what's involved. I did have a really interesting experience relatively recently where I was on a clinical observership in Canada and actually observed how they prepare patients for treatment. They do have the advantage in Canada that they don't have to necessarily have people attending the pharmacy daily and being sort of registered with a permit in the same way. But I really like the way that they introduce the conversation around starting on treatment. So, in this one example, there was a woman who was using short-acting opioids. She was using them multiple times per day. And when she was talking to the pharmacist about how her medication was affecting her, she'd have her dose, she'd feel better for, an hour or two, and then she'd sort of start to feel pain again, and she was going up and down over the course of the day. Now, that pain was actually more likely to be opioid withdrawal or partly opioid withdrawal that was worsening her pain. And the way that the pharmacist introduced the treatment to her and the standard way that they describe it in this setting was that, look, you're on a short-acting opioid, you're cycling in and out of pain all day. What we can do is transfer you to a long-acting opioid. You only need to take it once a day, and it's actually a much safer opioid, so it's going to reduce our concern about you potentially having a severe effect on your respiration that can affect your safety. And so this is the conversation, the way it's presented. It's a long-acting opioid. Your pain will improve because you're not cycling in and out of opioid withdrawal all day. And the conversation really wasn't about opioid use disorder or dependence, even though it's more likely that the patient that you're speaking to may also be experiencing those things. So I guess those phrasings or thinking about that when having conversations with patients might be useful. The other thing that I always like to talk about when I'm talking about pharmaceutical opioids is this idea of opioid safety and having a really patient-centred conversation. And we're very lucky now that take-home naloxone is becoming much more available, and I think that's a nice way to talk about opioid safety when people are considering treatment. It can, I guess, highlight the fact that there are safety concerns, and that's one of the reasons why somebody might be motivated to go onto a more stable, regular dose of opioids through a treatment program. I guess we've done a bit of research around this, trying to understand what patients experience about it, but in general, I think it's a nice patient-centred way to start a conversation about safety and also be able to offer something that patients can take home and have in their home with them in the way of take-home naloxone. So I think in having this conversation, we can talk about what the risks are for opioid toxicity and also the risk of polypharmacy. Often patients who are using pharmaceutical opioids in a dependent way are also using other medicines like benzodiazepines, pregabalin or Lyrica, maybe a range of antidepressants, some of which might be sedating. So I guess being able to raise, there's a range of things that might affect someone's safety and letting people know what they are. When having these conversations, it's really helpful to involve a family member or carer so they know, for example, where naloxone might be kept in the home, what it is and why somebody might have it. It's not very helpful to have naloxone if somebody is in an opioid toxicity state and nobody else knows that it's in the home or what's happening for that patient. Now, some of the research that we did actually asked patients with chronic pain who are on long-term opioids. We explained what naloxone was, something that they could have in the home, that a family member or carer could administer to them if they'd had a very bad reaction to their opioids that was affecting their respiration. When we explained it to patients like this, we found that the overwhelming majority said that they would not only appreciate, but they would expect to be offered naloxone by a healthcare professional if it was explained in that way. And most of them thought it was a good or a very good idea. So it's often a concern that we might be afraid of offending patients, but it is something that I think we can do that's very patient-centred and around safety. And we know, as I mentioned at the start of this conversation, many lives are lost to pharmaceutical opioid toxicity. Naloxone is now available in pharmacies without a script, and there are actually a number of pharmacies that are providing it free of charge in Victoria. In terms of kind of what it is, I think it's important that we explain to patients that it's something that they have. It's kind of often a fire extinguisher analogy. It's just something that you hope you never use, but it's good to have at home. There are a couple of steps to providing take-home naloxone, and this will often happen in the pharmacy if you're referring patients to the pharmacy. But along with supplying the naloxone, there's education for patients around what opioid toxicity symptoms are and when to administer it. And then at the time of an overdose, then we have sort of the layperson's able to administer that while waiting for an ambulance. In terms of opioid toxicity, again, we know that while people who inject drugs are typically familiar with most of these symptoms and will get questions around opioid toxicity, almost all of these questions right without any training, people who are prescribed opioids for pain are largely unfamiliar with these symptoms. In our research, they got almost all of the questions wrong. So we really do need to start from assuming a low baseline knowledge. So you can see here, and this is actually from a prescription cover that's used in New South Wales, signs of opioid toxicity, often referred to as an overdose, although I'd note that that language isn't particularly helpful for people who are prescribed opioids. They don't really relate to the term overdose. But the signs it depends on what's been taken, but symptoms like the person is like not moving or can't be woken, so, really trying to talk to someone and there's really no response. Tiny pupils, slow or absent breathing. A really classic sign of respiratory depression is gurgling or snoring sounds. So again, letting family members know that if they hear that, that's a sign of opioid toxicity. And there's sort of blue or grey lips and nails and a clammy feeling skin. So again, educating patients and family members about these. And just the steps, again, making sure people can identify those signs and symptoms, making sure they know to call the ambulance, and then administering naloxone. It's available in a nasal spray. The pharmacist can explain to you how to use this, but generally administer one dose, and then after 3 minutes, if there's no response, a second dose can be given. and staying with the patient, popping them in a recovery position. Again, just very quickly highlighting that there are a couple of different formulations. With the nasal spray, very important to tell people not to prime it. Don't squirt it until it's in the nose because there's only one dose. There is a syringe, a pre-filled syringe that you can also access on the PBS or over the counter in the pharmacy. It's a little bit more complicated, so we often don't necessarily recommend this for patients who've never had any experience with using syringes or if their family members are very unfamiliar. But if this is the only thing available or if this is what people prefer, you need to attach the needle tip, hold it like a dart and inject it on a 90-degree angle. And it can be given through the close. In this Prenoxad product in the yellow box on the bottom there, it comes with 5 doses, so also to let people know to only use one increment. Again, a pharmacist can go through all of this, but it's useful to know the products that are out there. So I guess just to finish up, I wanted to go back to what happened to Helen. So Helen talked to her GP and she was not interested in opioid agonist treatment at that time. So she was willing to trial reducing off her current opioids at home. And she gave that a trial. She was trying to reduce at a dose of 10% per week. But she was finding whenever she reduced her dose, she was experiencing a lot of craving, her headaches returned, and she always ended up increasing her dose and topping it up rather than reducing. And ultimately she started using the prescribed codeine and oxycodone. And again, it was just too hard to go through this withdrawal and keep going to work. So she came back and after this experience of trying to reduce on her own, she was willing to try a buprenorphine taper but not interested in long-term treatment. So Helen's current GP wasn't really confident in prescribing any of these medicines, so she referred to a GP that was currently prescribing buprenorphine, and so they started on a short-term taper. And what actually happened, and this is not unusual, is that a week or so into the taper, Helen was actually finding that she was actually feeling pretty good on the medication, and she decided she'd prefer to stay on it a little longer rather than come off in a short-term taper. And this is, often this is kind of like, I guess, a gateway to treatment, a little bit of experience with this medicine, and people realise that it feels okay, and they prefer to have that sort of stabilisation rather than come off straight away. So she stabilised on a dose of 12 milligrams. She was getting twice weekly pickup, and I guess I would highlight that Helen was lucky that she had a GP that was very experienced and was able to go a little outside the guidelines and start some unsupervised doses fairly quickly because Helen had a range of protective factors and she had no history of injecting other drugs. She wasn't using any other sedative medicines, and we do sometimes see this, a little bit of flexibility where a patient appears to have very few risk factors to be able to get a little bit more flexibility in their treatment. Also, Helen had a mental health care plan set up because she was experiencing a lot of anxiety around her relationship separation, and just to get a few more strategies to cope with that without using additional medicine. So in the end, her GP was thinking maybe she could take over prescribing the buprenorphine naloxone now that Helen was on it, and I think that's a really good outcome if we can have people return to their usual GP and have someone's care managed just by the one person. So there's lots and lots of information. If you have liked this and want to learn a little bit more, lots of information on the Department of Health website about Victorian pharmacotherapy policies and the treatments that are available. Also, there's information about these treatments in the prison system. I've put a reference there to the Cochrane review that we did, which has a lot of detail about the research if that's something you'd like. And also there's a frequently asked questions document that I drafted, which covers a lot of the information and might be useful in sort of some things to talk about with patients and things that often come up around opioid agonist treatment for pharmaceutical opioid dependence. I've also popped on the right-hand side, this is a Victorian service, DACUS, which also services Tasmania and New South Wales. Most states have some equivalent of this, but this is for healthcare professionals, a service that you can call, and there is also a Safe Script advisory service, where if you've got a patient, you've got Helen and you're really not sure what the best options are, and you want to talk it through with someone, you can contact these specialist services and get some advice. So that's probably enough from me. Really grateful to have so many people join us for the webinar, and happy to answer any questions if we've got some.
Thank you very much, Susie. That's exceptionally informative. I think that was a great overview of looking at some of the complexities of people, looking at longer treatments around longer acting pharmaceuticals. Something that occurred to me was in your research and your exposure to this, are you seeing differences in age groups who might be interested in, and maybe gender differences in people who might be interested in transferring over?
That's a really excellent question, actually. When we compare populations of people who enter treatment with pharmaceutical opioid dependence, they do typically tend to be a little bit older than what we traditionally have seen with populations who use heroin, and also tend to have a greater proportion of females. So usually in sort of traditional opioid treatment populations, they're predominantly male, 2/3 to 3/4 male. We actually have in our pharmaceutical opioid populations, depending on the opioid, with codeine, for example, the majority have been female. With other opioids, around half male, female. So we do often, we often are seeing those older adults and more of a mix of genders.
Okay.
So and that might come with some differences in terms of how you approach treatment as well.
Okay. And in terms of regional accessibility to these types of treatments, what's your experience of that?
Yeah, look, that can be challenging, particularly because often when we get further away from metropolitan centres, we are relying very much on GPs to provide these services. So in some regional areas, it is a bit of a longer travel distance to be able to access those GPs. In some regions, we do actually have nurse practitioners who are filling that gap very nicely and making sure that there is sort of good access in some of those regional rural areas. But it is worth trying to identify, I guess, if you are in a regional area, who in your area might be prescribing and what options there are.
Okay. I'd just like to remind people too that Susie had an opportunity to receive some questions earlier when people registered for the webinar, and she's very nicely incorporated those questions into the presentation. So thank you for doing that. If you've got any outstanding questions, you can be contacted via emails.
Feel free to email me. I'm actually very happy to chat about this at any time. And if there was something that I didn't cover or something that you'd like more information about, very happy to be contacted.
Okay. And Susie's also kindly made her presentation available. So if the slides don't come up or the PDF doesn't come up on your screen at the moment, just refresh your screen. They should be there. But otherwise, I'd like to thank you very much for making your time extraordinarily busy and well sought after presenter. So thank you very much again.
It's a pleasure.
And it's a wonderful segue to the next webinar, which will be the long-acting buprenorphine in treatment of opioid disorders. And if you can register for that again at Redback, or if you want more information, always go to the VADA e-news as well. So thank you very much for being with us today, and we look forward to seeing you at our next webinar. Thank you.